Hi, my name is Jason Libby. I'm a nurse practitioner here at Hospice of Southern Maine. I'm certified as an advanced practice nurse in hospice and palliative care, and I have been doing this work here at Hospice of Southern Maine for a little over 10 years at this point. And I'm going to talk today a little bit about the management of symptoms with hospice patients. This should not be seen as the definitive guide on medications or the specific approach to management of symptoms and suffering in hospice patients. Rather, this should be seen as an introduction and an overview of how we typically approach symptom management for our patients. So two of the things that we need to talk about right off the bat are symptoms and suffering. Well, what does that mean? Well, symptoms are some things that we all can recognize. We can think about pain, we can think about nausea, shortness of breath, anxiety, restlessness. We've all felt some of these things to some extent throughout the course of our lives. The difference with hospice patients is that we are often dealing with causes that we know cannot be reversed. And so what we have to do is focus on treating those the very best we can. Along with symptom burden like pain and shortness of breath comes suffering. Suffering is a little bit more intangible, a little bit more difficult to describe, but it's something, again, that we all sort of recognize when we're seeing it. Part of the multidisciplinary approach to the management of symptom burden in hospice patients is recognizing that suffering is not always physical in nature. That sometimes there is spiritual suffering, there's psychological suffering that we need to help mitigate as well. We're not really going to talk specifically about that now, as that's been addressed in other areas with the approach to hospice patients, but it's going to be something we need to consider as we talk about things going forward. So common symptoms at end of life usually include pain, respiratory symptoms, and that can be shortness of breath, that can be persistent cough, that can be pain with breathing. And along with these, sometimes comes a sense of anxiety. And there really are a couple kinds of anxiety when we talk about this. We have the anxiety of, did I leave the toaster on when I left home this morning? And then there's the anxiety that comes along with being confronted with your own mortality. Those two kind of sit in the same sort of, psychological sphere. Then you have the anxiety that is a physiological response to pain and suffering. Think of it as the fight or flight response. Again, we've all been there to some extent. The difference with hospice patients is that sometimes these things that are causing that fight or flight response aren't going away. So we need to be more aggressive about how we manage the effects of that. Sort of in the same line for that would be symptoms of delirium and agitation. Delirium and agitation are very common at end of life. They can also occur further along the disease process, and it is as distressing, perhaps more so, than physical pain, both for the patient and the caregivers. So we need to be especially attentive to the effects that can have on people as well. So what is pain? Well, we all experience it. It's part of the human condition. But when we're talking about things from a clinical perspective and how we approach what people are telling us, our approach is that pain is whatever the person says it is, experienced whenever they say they're experiencing it. Part of what we need to do as clinicians is try to elicit from a patient, what kind of pain is it? Is it stabbing? Is it aching? Is it fiery? Is it coming from your back? Does it happen when you're sitting still and feel better when you move? Is it the opposite? What's causing it? What makes it better? What makes it worse? It's not just give me a number to your pain. You really have to try to understand where this is all coming from. Is it purely physical? Is it being exacerbated by your anxiety? These are things that we don't always find the answer to, but if we make an effort to try to figure that out, we can sometimes tailor the approach to the management a little bit better. Why is managing pain so important? Well, aside from the obvious, that you are uncomfortable when you're in pain, it can significantly improve quality of life by allowing you to be more mobile, by helping you to be a little less short of breath. And those sorts of things really are the focus of what hospice is supposed to be doing. We really are trying to help improve quality of life as best we can. So that's sort of the most obvious part of why we'd want to manage these symptoms of pain. Maybe less obvious is the phenomenon that we see in our practice consistently is that inadequate pain relief can actually hasten somebody's death. Some of this is a little bit ephemeral as to why this happens, but what we do know is that the increased physical stress response, again, that fight or flight response, really puts you at a risk of more precipitous decline, functionally, physically, if you will. But there's also the psychological distress of being in pain and suffering constantly, and it is both physically wearing and psychologically wearing. And we definitely see that people who, for various reasons, either cannot or choose not to have more aggressive pain management, sometimes do actually have a shorter hospice course. On the other side of that coin, and we see this with people who are very near the end of life, unrelieved pain and suffering at the very end of life can oftentimes act as an anchor, and that anchor keeps you stuck here. And you have to decide for yourselves what you think about, the idea of, a person who is not aware, how much can they perceive and how much they can understand. We don't really know that, but what I do know from long years of practice is that people who have unpalliated physical suffering oftentimes cannot seem to complete that final step in their journey, which is, of course, death. But people can be stuck in this interminable phase where they are clearly physically suffering but can't move along. And that is as hard to see for patients, families, and the clinicians, honestly, as well as anything else. So there are a lot of good reasons why we really do need to focus on aggressive pain management. I talked a little bit already about, how do we assess that? We're asking them, what kind of pain do you have? Is this different from the pain you've had before? People come onto our service perhaps with tumor burden from cancer, and that may be enlarging. The swelling from that tumor may be increasing. So it may be changing the location, the severity, or the quality of their pain. And so, we have to have a very much non-dogmatic approach to how we are treating this. And part of that is good ongoing assessment. We always want to know the location. We want to know, the timing. Again, like I said, what makes it better, what makes it worse, because these things really can help guide our treatment. And it's not always just narcotics that are the right thing to treat. If you are identifying something that perhaps is a GI upset, think about, progressive ulcer, reflux disease, may be causing significant pain in a patient who perhaps cannot really delineate what that pain is or how bad it is. And so you have to always kind of keep your mind open to the possibilities that even people with severe end-stage disease of all stripes can still have discomforts associated with the sort of normal chronic disease processes that anybody might have. So you can't forget either the sort of meaning of pain to somebody, perhaps within their own culture. And again, I am not going to hold myself out as an expert in any way about the various cultures that we might encounter here in hospice. But some people definitely do see pain as something that they are either meant to suffer and need to suffer, or they see some sort of requirement that they do so in order to demonstrate their faith, demonstrate their toughness to themselves or their families. And so that really comes into the mix when you are navigating medication decisions with patients and their families. You really do need to make some effort to understand what else is affecting somebody's concerns about using pain medications. Probably more common, at least in this area, than cultural issues are concerns and worries about addiction, concerns and worries about becoming dependent on narcotic medications. And you can do a lot with educating and consistent messaging with patients and their families about this, but sometimes they've had family experiences with loved ones that they really just can't psychologically get over. And it can be a little bit tough to sort of help them understand why their situation might be different. You can't push people to do anything they don't want to do, and you should never try to do that, but providing good education and expertise is really fundamental in helping people not only tell you about what's going on with them, but helping them decide on what the best course of treatment is. you see acute pain versus chronic pain. These things don't exist in vacuums for many of our patients. They are occurring at the very same time. They may be from two different causes. So again, that goes into your thinking about what is the right choice of medication for somebody. Patients who are at under risk for under treatment comprise, a large number of our patients. The elderly population, for various reasons, is at risk. Sort of talked about the concerns and worries about addiction or becoming dependent or being knocked out or fuzzy, that these are common beliefs shared by some of our older patients. And I don't mean to besmirch the elderly, because this is something that anybody can believe in. But honestly, this is something that they do tend to struggle with from a decision-making standpoint more than some of our other populations. And so again, providing them with education about why and how we use narcotics can be really important. Other nonverbal or cognitively impaired patients are also at risk. This is because, well, very clearly they cannot express clearly what they are feeling, and either their family members or the staff where some of these residents may live, they may not have the experience or the education to understand some of these nonverbal cues of pain that people may show us when they can't report it more clearly. This shows up as sometimes aggressiveness or agitation with care, withdrawal, impaired mobility, and it can be difficult to parse out from perhaps some of their behavioral issues, but this is where a skilled hospice provider can really lend a lot of help to care, because they really can see, recognize, and advise treatment for those things when they're occurring. So some of the common medications that we use for pain management in hospice are going to be really familiar. Obviously, we use an awful lot of morphine. The reason being, it's easy to use. Most clinicians are comfortable with the dosing ranges, and there are very few pre-existing medical or clinical reasons why you can't use morphine effectively. Other common medications, narcotic medications in hospice, would be transdermal fentanyl patches, oral oral oxycodone for our outpatients, occasionally codeine. And methadone is a absolutely superb pain medication that we really probably don't use enough of in our particular practice. That also has a lot of connotations in the public at large as well. Another medication we use is Dilaudid hydromorphone. And with the morphine and Dilaudid, we use those both as oral preparations, and for our inpatient hospice, we use those as IV as well. A really common narcotic found in the community is oxycodone. Of course, we all have, over the years, heard about issues with oxycodone. While it is very popular, the experience of hospice patients oftentimes demonstrates to us that it doesn't seem to be particularly effective for their pain in the long run. And we oftentimes will try to transition them to other medications if they're amenable to doing so. Again, that's not a hard and fast plan. We don't absolutely have to do that. But our experience, both as a group and mine individually as a clinician, really points to oxycodone probably not being the very best medication choice overall. Going back to methadone a little bit, some of the restrictions with methadone are largely centered around clinician comfort level with using it. It has vastly different pharmacodynamics as compared to the other drugs that we use, the morphine and Dilaudid specifically. The length of time that it takes to achieve effectiveness, how you manage the titration, as well as transitioning to and transitioning away from methadone can sometimes scare off other clinicians who aren't as familiar with it. This is another great reason why, when it's appropriate, you really should bring in hospice, because these are things we can help manage. And methadone works very differently than a lot of the other pain medications, and in some instances really does offer superior pain management without some of the side effects of the other medications. So it can be a really great adjunct to things. So how do we choose which of these medications we're going to use? Some of this is driven by data. Some of this is driven by experience. I think if I'm being honest, a lot of my decision making is driven by experience with this. We generally will try morphine first unless somebody has a specific allergy, has a really bad history with it. Those histories can be severe nausea and vomiting. Some people's gastrointestinal tracts are slowed down so much that they really do have acutely negative effects from morphine. Very few very few true allergies to morphine that I've seen in all these years, but it does occur. We like morphine because the side effect profile is really well known. People tolerate it really well. The dosing ranges are usually consistent from one person to the next. There is not a huge range of either effective or potentially dangerous doses. We all sort of respond to it in the same way. And that sort of makes it a great fit for a very varied population. Another great medication is hydromorphone, Dilaudid. We do use this when somebody has a real morphine allergy. We also turn to this when somebody who has severe end-stage renal failure. The accumulating metabolites of morphine and renal failure just continue to recirculate, and that makes it really difficult to know what is the actual effective level of the morphine metabolites within somebody's system. So we do try to avoid morphine in those specific cases. That being said, somebody who is actively dying and has had good relief with morphine, irrespective of their renal state, we would still probably use that if it has demonstrated effectiveness. Again, kind of referring back to the oxycodone, we see a lot of mixed effectiveness for pain management and even less so for shortness of breath. We will talk a little bit more about using morphine for shortness of breath, but it just does not seem to have the same predictable outcome as compared to the other medications that we use. Also, too, we see a lot of patients talk about a significant hangover feeling from the medication when they're not taking it, and then that ends up discouraging them from adequately medicating their pain later, and so we kind of get into this cycle where somebody's not treating their discomfort because the medication that they were using actually made them feel a little bit worse when they weren't taking it. So we try to transition people off of that when we can. Other choices are transdermal fentanyl patches. These are great because they require very little supervision. You don't have to remember to take something once or twice a day. And when you have a patient who has adequate adipose tissue, that is not too much and not too little, they are really effective at managing all sorts of pain. And they're pretty easy to titrate. We understand pretty well if somebody is taking oral medications as breakthrough. We know pretty well how to change those fentanyl patches to follow that along. So they can be effective. We use those a lot when we have patients with family members perhaps who are struggling with managing pills. Sometimes patients who are in facilities, they just end up being a lot easier to use. There's not usually the first choice for acutely dying patients, just because the time needed to have them take effect and titrate up we usually don't have. But for people chronically on hospice, weeks, months, they can really be an effective part of the management. Another part of pain management that we do with hospice patients can include continuous medication infusions. So whether that's Dilaudid, whether that's morphine. Sometimes patients do better with a continuous infusion of these medications via a pump, a patient-controlled analgesia pump. And we are absolutely capable of using those both in our home patient population and the Gosnell Memorial Hospice House. These can be great when you have somebody who has a really high narcotic requirement. And it really cannot be effectively delivered in another way. It can significantly improve not just their comfort, but their functional status as well. Excuse me, as well. So this oftentimes requires an indwelling catheter, whether it's a midline, whether it's a PICC line. Sometimes these patients already have They have access from their prior treatments. That makes things a little bit easier as well. But our nurses can not only handle the access of those lines, but they would be monitoring the use of the medication, reporting back to the hospice providers so that we could determine if we need to do further titration or not. Again, morphine and Dilaudid are the most common. We do sometimes use fentanyl in people who can't tolerate either of those medications, but generally those are both well tolerated and can be really significantly beneficial for somebody. So one of the things we talk about when we are advocating for aggressive symptom management is that, this part of life is really hard. And whether you're a transition to, dying takes a few days, a few months. We have patients who sometimes this takes a few years, if you can believe it. One of the quotes that I think best sums up this tough part is by Isaac Asimov. And he said, life is pleasant, death is peaceful, it's the transition that's troublesome. And it's true. This work has really demonstrated to me that it is the transition that's troublesome, and this is where hospice comes in. We want to try to help make this transition a little bit easier. I never tell people we're going to make it easy. I never tell people I'm going to take away all their pain. I'm going to tell them we're going to work really hard to make sure we treat these things as the very best we can. So in that line, one of the most disturbing symptoms right along pain is dyspnea. So what is dyspnea? Dyspnea is technically being aware of your breathing. And we generally, as you all know, until I've said it, you weren't aware of your breathing. Now you're thinking about it. What we're talking about in hospice context when we're talking about dyspnea is that awareness of your breathing that is distressing. It can be terribly frightening when it comes on acutely. And for people who are living with it chronically, it's incredibly frustrating. When it occurs acutely, you have somebody perhaps who has never had any restrictions on their functional status, and now maybe they can't talk or they can't chew and swallow without becoming short of breath. And that really can be not just incredibly frightening, but incredibly frustrating. We do have the ability to help mitigate that to some extent. Not just the ongoing chronic medication management of somebody with, say, end-stage COPD or emphysema, but also acute medications, morphine, Ativan. We're going to talk about that a little bit more as well. So it's not something that just goes untreated, and it's really something that people don't recognize as a symptom that can be made better. And as much as treating somebody's pain can improve perhaps their functional status and their psychological well-being, improving somebody's sense of dyspnea can be incredibly beneficial, even when you're talking small improvements. If you have a patient who is struggling to chew and swallow and they're losing weight, but they have an appetite and they are hungry and they want to eat, but it's incredibly distressing for them to do so, managing that dyspnea so that they can chew and swallow without feeling like they're gasping for air can be a pretty monumental improvement in their quality of life. Another example is somebody with COPD who perhaps is no longer able to get up from the couch by themselves because it is just so stressful for them from a respiratory standpoint. Adequate management of that can perhaps, not only can they get up, maybe they can actually walk 5 or 10 feet where they weren't able to do so before. And though that sounds very small, I think it's very easy for us all to understand that not being able to do that to being able to do that is huge. So management of this symptom should not go by the wayside at all. Common causes, like I mentioned, COPD, any other sort of chronic respiratory disease caused by either heart failure, by environmental exposure, by space-occupying masses, cancers, you name it. They can all produce dyspnea. Physical expansion of your abdomen, say with ascites from end-stage liver failure, that also can cause dyspnea. And that at that point, it's because you can't get that expansion that you need, but the sensation that you feel remains the same. And it's incredibly frightening and incredibly disheartening. It can really affect somebody's ability to sleep. Like I said, it can affect their ability to eat. It can affect their ability to communicate. If they can't participate in the lives going on around them because they can't even move, these are things that we can definitely help with. There are non-pharmacological management tips for this sort of thing. Supplemental oxygen can go a long way towards making somebody feel better. Again, it's not going to solve the problem, but if part of the problem is that your brain is on constant high alert because you have oxygen saturation levels that are too low, simply bumping those up even a little bit can turn down that panic alarm in your brain, and you don't have that same sensation of being so short of breath. We teach patients energy conservation, parsing out tasks rather than trying to do all of getting dressed at one time. Maybe get your shirt on, catch your breath, then get your pants on, catch your breath. Sounds very simple, but if you go through your whole life just doing things the way you do them and not having to think about how your body is going to respond to it, this can actually be a revelatory education for somebody. And when they start doing those things, they do find they can tolerate them better, and they're not quite so exhausted after doing simple tasks. The other thing that we sometimes see helps with dyspnea, and I don't understand why this is, I've tried to educate myself and there's no real clear consensus, is the simple movement of air with fans. Patients with severe respiratory failure oftentimes provides significant relief, and I would definitely recommend trying that on anybody who's feeling short of breath for any reason. So, transitioning and thinking more about the medication management for dyspnea, it's a no-brainer. The go-to drug for us is morphine. There really isn't a better option for management. By the sort of chemistry and by the science, any of the narcotics ought to work. They ought to do the same thing, but our experience is pretty clear in that they don't. There really isn't a better drug, and the way it works, and again, this is in very general sense, is what you're doing is you're decreasing cardiac demand. You're also increasing cardiac perfusion. You're increasing pulmonary perfusion with the use of morphine, and we all know this from our training days. One of the first things you do when somebody comes in having a cardiac arrest, or rather chest pain, is you use morphine. But it also is working within the brain, within those sensors that are sort of setting off that high alert that, our oxygen level is too low, our carbon dioxide level is climbing too high, I need to panic, panic, panic. So it really is just the best thing going for this. It oftentimes doesn't take a lot to make somebody feel better. Low doses, orally, starting off at 5 milligrams, before they're going to be short of breath, when they are short of breath, after they've completed an activity, can really significantly improve somebody's quality of life. Oftentimes, the morphine alone isn't necessarily going to do the trick, and you will also need to use benzodiazepines. So, and the most common one that we use is Ativan. They work together to fight this sensation or fight or flight that you get when you are short of breath. So, if you're having a hard time visualizing this, we've all had that feeling of being underwater a couple seconds longer than we care to, and your brain is just firing on all cylinders like, I'm panicked, I gotta get out of this. So, like I mentioned with the morphine, it helps with some of that, and then the Ativan is also fighting that anxiety response, that physiological anxiety response that comes from being short of breath. These can be used on an as-needed basis. They can be used on a scheduled basis as well. Obviously, we usually start off in an as-needed, and what we try to get patients to recognize is, identify those activities that are going to make you short of breath, and let's try to pre-medicate you a little bit beforehand. And I'll tell people, take these, either one or the other or both, 30 minutes before you're going to get up. Take another dose maybe, as you're getting up. And then if you're feeling really short of breath when you're finally done with activity, think about taking it again. We start low, we go slow, we always do, and we want to try to find that effective dose for people. But a lot of the times it's an uphill battle until people finally take it, and then universally they will tell me, I wish I had just done this sooner. It's an ongoing conversation. We never tire of providing this education, though. So dovetailing with respiratory distress is cough. And coughing, we all have some experience with this. I think we can all have some empathy with that persistent, really uncomfortable cough that we've all had at one point or another. This can be really frustrating and debilitating, especially when the cause of this cough we know is not going to go away. The coughs themselves can end up causing significant pain, fatigue, vomiting, insomnia, and really can be quite distracting and and causing negative effects of somebody's quality of life. So, cough can be present in so many disease states. We're talking about bronchitis, no matter the cause, congestive heart failure, lung cancer, in the respiratory derangements that you might see with HIV or AIDS. Really is something that can occur in many different causes that might land you on hospice. And so it's something we do need to pay attention to, although maybe it's not as often or as common, rather, than some of the other symptom burdens. The good news is we do have some effective interventions for this, and these range from sort of the baseline over-the-counter expectorants or antitussives, think guaifenesin, the dextromethorphan, and ranging up to things like steroids. They can really be very effective either in acute or in chronic dosing. We used dexamethasone, Decadron, prednisone as well. And oftentimes patients who have this issue have some experience with it previously, and they can actually help guide us. Well, when this happened before, I used this and it worked well. Sometimes they are new to that, and then we just have to be a little bit conscientious that using steroids in the context of some significant disease burden may end up with some negative consequences that we want to avoid. Another class of medications are the anticholinergics. Probably the most common one that you would know about is a scopolamine patch. You might have even seen that for seasickness. These work by trying to dry up some of the upper respiratory secretions that may be actually dripping down and causing this irritating cough, decreasing some of the secretory volume within the alveoli themselves, and trying to diminish it from that end. And then another tier is going back to the narcotics. The narcotics are fantastic antitussives. There are few things in the world better than codeine cough syrup when you've really been hacking for days on end. And though it's not necessarily something we want to use chronically for patients when they are having exacerbations, it can be incredibly effective, and I do lean quite heavily on the codeine for those people who are having severe symptom burden from this. So the next thing I want to talk about is anxiety. And anxiety is that subjective feeling of apprehension, feeling of tension, feeling of insecurity, uneasiness. Oftentimes we really can't pinpoint what it is. Sometimes we very much can pinpoint what it is, but it doesn't necessarily mean, even if you know what the problem is, that you can solve it. We've all had anxiety, and if you hadn't, before, if you are very sick, very ill, in a lot of pain, in a lot of distress, you will have anxiety. And this, much like the shortness of breath, should never be given short shrift. Everybody can easily think about managing pain when you're talking about people with end-of-life disease. But that pain, that shortness of breath, anxiety, they're all as important because they really do all contribute significantly to quality of life. So causes of anxiety for our patients are oftentimes physical pain. We talked about the physiological stress that comes along with activation of pain, being short of breath, and then having confusion. If you have somebody with dementia, somebody perhaps who is starting to develop confusion because of end organ damage from renal failure, from liver failure, the agitation and the delirium that start to occur with that, while somebody is still very much aware that that agitation and delirium is occurring, can be incredibly anxiety-provoking and needs to be treated as well. Sometimes it's the medications that we are either hospice providers are using to treat some of the symptoms, or perhaps some of their chronic medications are exacerbating this. You think about any of your stimulants. Steroids are classic bad actors for this. Thyroid hormone replacements and some neuroleptics can really exacerbate either underlying pre-existing anxiety disorders or anxiety that's being caused by acute symptom burden of pain or shortness of breath. And nobody comes to hospice with a clean slate. You don't just show up, and you're a hospice patient. You carry your whole lifelong health along with you, and that may very well include an underlying psychological history of anxiety disorders or any other psychological diseases that put you at risk for either, anxiety in and of itself or to have a really hard time handling any anxiety above your baseline. So, it's difficult to assign a number or assign a graph or, give me, a hard data point on how your anxiety is feeling. You oftentimes have to work with somebody within the context of how they can explain it to you. And sometimes the easiest way is to ask them, how is this affecting your life? Is this, completely debilitating? Is this just bothersome? Can you not leave, your chair because you're so worried about perhaps fracturing something when you get up, or can you not sleep at night because you are focused on all the what ifs about end of life? Those are all completely valid. They're all just as real, and they're all affecting quality of life for that patient. They may experience profuse sweating and tachycardia, restlessness, agitation, and behavioral changes. Somebody might be very frustrated and nasty, where they've always been the very kindest and most calm of people. Any sort of deviation from their baseline, you could definitely pin on anxiety. So, how do we treat this? Well, again, this is not the definitive psychological, lecture on how one manages anxiety in a broader context. First and foremost, recognizing that people do, again, come to us with underlying disease, it's reasonable to explore if any chronic medications they are on for management of an anxiety disorder can be further titrated. That is something that either the hospice provider would work on their own, or we might contact their PCP or their psych provider and try to figure out what the best course of action would be for that. In situations where somebody perhaps is coming to us without that sort of underlying disorder, and we can absolutely attribute this anxiety to the physical distress of their disease, again, shortness of breath, pain, organ failure, then we oftentimes turn to our benzodiazepines, and the two favorite ones that we like to use are Ativan and Valium. These are both short-acting medications. Both of them have really well understood side effects profiles. They also are really, pretty universally tolerated in the same way. We know how long they'll last. We know sort of what the right dose to start at for somebody would be, even if they've not had them before. They both work really well. Sometimes we, find that somebody is having a paradoxical reaction to Ativan. That is, it seems to be making them perhaps more anxious, or it's causing them to be restless, or it's causing them to be confused and agitated. It's reasonable then to try to transition to Valium, and though both of these drugs are very similar from a chemical makeup standpoint, there does sometimes seem to be a better tolerance of Valium for patients, and so it's very reasonable to think about making that call, even though you are using just another benzodiazepine. There is rightly, some concern about using these medications in elderly patients, especially elderly patients with dementia. It's pretty well known that this is a medication class that can exacerbate behavioral issues, but oftentimes it is worth trying that and evaluating whether or not they would tolerate it, even if perhaps in another setting in the past they had not tolerated them well, because they do work so effectively for managing anxiety, pretty much irrespective of the cause. And I think that's probably worth mentioning at this point, that most of these treatments that we're talking about are very much cause agnostic. That is, irrespective of what is bringing this symptom burden to the patient, these medications are going to most likely work effectively to help mitigate them. And that's because these medications are oftentimes aimed at the most basic part of that course of reactions in your body that cause those symptoms. So we're kind of going right to the most basic parts of these with these treatments. In that light, we're going to talk about delirium, agitation, and confusion. This is incredibly terrifying for somebody who's experiencing it. We don't oftentimes have patients who come in and out of a state where they are in this delirious or agitated state who can then kind of relate to us what it was like. The few times I've had somebody been able to relate that to me, it sounds like it was just scary, it was terrifying, and it was really uncomfortable. So delirium and agitation, delirium is really an acute change in how you are perceiving the world around you. It's an acute change in how you are aware of tactile sensation, auditory input, you name it. Any of your senses can be affected by delirium. This sometimes manifests as agitation. It sometimes manifests as having hallucinations. But all of it really boils down to becoming disoriented, confused, perhaps having aggressive behavior, acting out, and is something that cannot be let. We just can't let it go by. It's something we really do have to focus on managing. It's nearly universal at end of life. And when I say end of life, I'm talking about those patients within the last days, maybe even the last couple of weeks of their lives. Irrespective of the cause of this, there's almost always some level of this agitation and delirium. Sometimes it's very minor. Other times it's incredibly severe and needs a very heavy-handed approach to management, not only to help palliate the symptoms, but to protect the patient from injuring themselves as well. This can be exacerbated by underlying psychological issues, whether it's exacerbated by them or we just find it difficult to parse out what's happening. It still confounds sometimes us helping to pin down the cause and whether or not it may be reversible. Most of the time, we aren't able to identify reversible causes of any of these symptoms. And again, this is why we're talking about what maybe sounds like aggressive management, but it really is appropriate for our patients. With end-of-life delirium and agitation, a lot of the times we're not going to come up with an exact cause in any case, which again is why we're using medications that are going to work irrespective of the cause. Relief of delirium, relief of hallucinations, relief of the suffering that comes along with this is incredibly important, and it's something that I personally spend a lot of time educating both the patients and their families on when we are talking about what end of life might look like, because it is so disturbing for the loved ones that are providing care for somebody that if you can prepare them for it, even if it never happens, if you can prepare somebody, it makes it easier for them to recognize it, report it to their home hospice nurse, so that we can get about treating it earlier rather than later. So treatment for this is, our toolbox is very small. There is a litany of medications that people use for psychoses, for agitation. In the outpatient arena, they are all good drugs. We're thinking things like Seroquel, we're thinking things like Zyprexa, Risperdal. We would definitely continue those for patients when appropriate. Some people come to us on them. Some people during the course of their hospice care, their primary care providers working with their home hospice nurses will start some of these other medications. But we like to reach into this very limited toolbox and use Haldol most often, especially for people who are very close to end of life. Now, Haldol has a very checkered past. Most recently, I think in the late 90s and the 2000s, I think most clinicians will recall that there were a lot of issues around Haldol, particularly within skilled nursing facilities, and concern that this was being used as chemical restraints for patients. I'm not going to speak to that here. I'm really rather going to focus on just how incredibly effective Haldol is in our patient population for managing these symptoms. Much like everything else that I've talked about today, Haldol is very predictable. It's easy to dose, it's easy to titrate, and again, it goes right to the kernel, right to that little speck in your brain that is really kind of causing all of this disruption in your sensorium. There really isn't a better option for terminal agitation and restlessness in an outpatient setting, both for a home hospice patient, and then we use this a lot at the Gosnell Memorial Hospice House as well. I think it's really important to point out that Haldol is not a chemical restraint in this setting. It really is an effective tool to bring some merciful relief from an otherwise horrible side effect of end-stage disease. And I think, it's very important that we focus on those sorts of things. One of the things about Haldol that really is a myth, and you may have heard it yourself, is that Haldol is in and of itself sedating. It's just not true. The pharmacology doesn't support that. What happens most often, especially with hospice patients, and this actually is true of any of the medications I've talked about, whether it's Ativan, whether it's morphine, it's Dilaudid, that what happens when people finally receive these medications, they oftentimes have been perhaps agitated and delirious and awake, sometimes for days, if maybe longer. And when you treat that impetus of agitated delirium, that thing that's driving that behavior, they're able to relax. They're able to actually go to sleep. And sometimes it will seem like you could drive them through, an exploding plant, and they would never wake up because they are so deeply asleep. And this is where, you see the same thing with people who have been in pain for a long time, when you see people who have had significant anxiety or shortness of breath and haven't been able to sleep for a long time. When you treat those symptoms, it can seem like, oh, I gave you morphine and you went to sleep. That is really not the case with Haldol, and it's very rarely the case with the medications that we use when we're using them appropriately for symptom management. I don't want to necessarily, harp on that, or I'm definitely not taking away from any personal experiences that patients or clinicians may have had. But over the course of long experience here, I can safely tell you that the use of Haldol, the use of Ativan, the use of morphine is not just knocking somebody out, not just sedating them. And if you see what looks like sedation, what looks like somebody, falling asleep and not being able to wake up after getting these medications, it's oftentimes because they are absolutely exhausted, and perhaps for the first time in weeks, days, or even months, they're actually able to get comfortable sleep. Like I mentioned, there are other treatments for this. Seroquel, Zyprexa, Risperidone, they are great drugs. We absolutely continue those when appropriate. They don't always come in the appropriate forms. Haldol is available both as an oral concentrate, an injectable form, as well as pills. So it really does make it it makes it the drug that we can use no matter where somebody's at in their hospice journey. The agitation or the restlessness that comes along with delirium is not usually best treated as first line with the benzodiazepines, but they can definitely be added in as an adjunct when you have tamed, hopefully, some of the delirium that might have been driving some of that restless and agitated behavior. As always, some of the non-pharmacological interventions are, having family presence, having a calm, relaxed environment. Anything that you have that is distracting somebody from whatever, maybe perseverative action they're going on could be good. And at the other time, the other side of that is, anything that's keeping somebody awake, anything that's keeping them focused on, the world around them might actually be causing them more distress. And so you have to, take each situation for what it is, its own individual, experience, and try to figure out the best advice for family and caregivers and help them with these non-pharmacological interventions for their delirium. So, again, we're talking about a lot of different ways to manage, a lot of these basic symptoms. None of this happens in a vacuum, of course, and the only way this gets done well is within the context of an interdisciplinary team approach to symptom management for patients. Practically, that is almost entirely handled by our home hospice nurses, who are experienced and trained in how to recognize, communicate, and treat all of these symptoms. They work hand in hand with both the patient's primary care providers as well as the hospice providers to assess what's going on in the home and to work with the providers to figure out the best strategy for managing those symptom burdens. And it's always a moving target. We could settle on something that is working really well for a few days and then find out that we have to change it again. And that is really an integral part of good symptom management through end of life. You need to have either your own self as a clinician say, I'm seeing patients at the inpatient unit at the Gosnell House, or I need to be working with the nurses in the field who can assess those patients and communicate to me what they're seeing, what they're feeling, what the families have told them about things, so that we can address the symptom burden and also try to come up with both non-pharmacological and pharmacological interventions that are going to be appropriate at that time. So it's not a one and done plan. It really does require ongoing evaluation throughout the entire thing. Hospice, you could be forgiven for thinking that it's all about coming to us and we push drugs on you and then we push you towards end of life. That's not true. Hospice really is all about helping to promote quality of life as best we can for people with life-limiting disease. And our goals are always to try to keep people as functional as possible, keep them engaged as possible, and while doing so, managing their symptoms in a way that allows that to happen if we can. We need families involved, we need people's care communities involved, and the things that we are doing, again, don't happen. It's not just a pill. It's not just an intervention. It's a team approach to all of this. And though today I was specifically addressing some of the pharmacological interventions, I think it's very important to remember that good hospice care is done by a team, and you can't get away from that. So I'd like to thank you very much for taking the time to watch this. If you've got other questions, hopefully you'll feel free to reach out to us. We're always available to help wherever we can. Thank you.